2, 1.
A warm welcome to today's topic. Today I'll be talking about an important UG and PG topic, stroke. Before going into the details of stroke, let's a little introduction. What is the purpose of CNS history taking an examination? The purpose is to find out whether the findings can be explained by a single lesion, multiple lesion, diffuse process, or does it fall into a syndromal pattern like motor neuron disease, Parkinson's, etc. So where is the lesion? Is it single, multiple, syndromal? And also you have to arrive at an etiological diagnosis, whether it is congenital, genetic, infection, inflammation, degenerative, endocrine, neoplastic, or vascular. What we commonly give you undergraduates is a vascular stroke. And also, what are the levels? Where is the lesion? It can be in the cortex, subcortex, internal capsule, brainstem, spinal cord, nerve root, plexus, peripheral nerve, neuromuscular junction, or the muscle itself. So these are the different levels where you can have a lesion. So the purpose is to identify where is the lesion, is it single, multiple, syndromal, or a diffuse process, and etiologically how to explain. Now what is stroke? Stroke is a condition where when the blood supply to a particular part of the brain is either obstructed or because of a bleed, the flow downstream, the tissue downstream will not receive any blood supply. So when it is deprived of the blood supply, what happens? That particular part of the brain will start to die off because there's no oxygen and there's no nutrients are also deprived. So that part of the brain starts to die off. So is this damage permanent? Yes, most of the time yes, because you have to intervene immediately to salvage or limit the damage. So stroke is a condition where there is one part of the brain, some part of the brain, the blood supply is interrupted either because of a bleed or because of a block, and depending on which part of the brain is affected, you will have symptoms accordingly. So abrupt onset of neurological deficit attributable to a focal vascular cause. That is stroke. That's the definition of stroke. Okay, what are the causes of stroke? What are the causes of stroke? It can be arterial or venous. It's venous is not so common because of cerebral venous thrombosis. What we generally see is an arterial stroke. Arterial stroke can be ischemic or hemorrhagic. Ischemic can be thrombotic or embolic. Okay. So what is an embolic? See, 75 to 80% of the strokes are ischemic, 20 to 25% are hemorrhage. Okay. So in ischemic you have thrombotic and embolic. Emboli is a moving clot which arises either from the heart or from somewhere outside the brain. Okay. Most common cause of emboli is from the heart. It can be because of a valvular heart disease. It can be because post-myocardial infarction, ischemic heart disease. You can have a clot which can travel up the brain, occlude any of the arteries and cause stroke. Another cause of emboli, source of emboli can be from the carotid. Because of the atherosclerosis, you can have a atherosclerotic plaque which can flick off, go to the brain and occlude one of the vessels. Thrombotic stroke, again, it is one condition where you have a block, the vessel inside the brain itself will have atherosclerosis and it closes. So the blood flow downstream is going to be affected and you can have interruption of blood supply. So thrombotic and embolic stroke. What is hemorrhagic stroke? Hemorrhagic stroke is a condition where the vessel bursts open. There's a torrential bleed inside the brain. Okay. The commonest cause is berry aneurysm, And another condition where you can have intracerebral bleed is because of AV malformation. AV malformation. Okay. So hemorrhage, one of the important risk factors is hypertension. Hypertension can cause intracerebral bleed. What are all the risk factors for stroke? The risk factors can be modifiable or non-modifiable. Modifiable can be smoking, alcoholism, hypertension, diabetes, dyslipidemia, coronary artery disease, chronic kidney disease, anything that accelerate atherosclerosis, like sedentary lifestyle, poor eating habits, are all risk factors which can be modified, about which you can do something about. Okay. Non-modifiable are age, sex. Okay. As you grow older, the chances of you getting a stroke is very high. Similarly, male is more prone to develop a stroke than female. But you have to remember that up to the age of 75, the chances of male getting a stroke is more than a female. But with 75, the female generally catches up and the incidence is equal. And also remember, if a female gets a stroke, it's generally more severe and fatal. Race, like Indians, Africans are more prone for stroke probably because of the eating and lifestyle habits. So you have modifiable and non-modifiable risk factors. What are all the symptoms of stroke? How can they present clinically? You have to remember fast, facial asymmetry, arm and limb weakness or numbness, speech disturbance, and time. Why time? Because time is brain. Every minute after a stroke, the brain loses about 2 million neurons. So the time is brain. You have to intervene early so that you can salvage the brain tissue. So you remember, apart from this, what are the other symptoms of headache is another important symptom of stroke, because especially in a patient who is having a bleed, is having a hemorrhage, severe unexplained headache is an important. That was speech abnormality. Similarly, vision abnormality, any problem with eye involvement can be a symptom of stroke. Any cranial nerve involvement can be stroke. And also, if you have a posterior circulation stroke, you can have incoordination, okay, giddiness, vertigo, unsteadiness. All these are symptoms of stroke. I'll just explain speech disturbance of aphasia. What is aphasia? Any abnormality in understanding, thought, and word finding ability is aphasia. Okay. So generally it happens and you have to remember, if the patient is aphasic, it means the dominant hemisphere is involved, because the speech area is in the dominant hemisphere. The dominant hemisphere is left in all right-handers, and also in most left-handers left to the dominant hemisphere. About 60 to 70% of left-handers and ambidextrous people, left is the dominant hemisphere. Okay. So if a patient has left-sided hemiplegia, a right-handed individual who is having left-sided hemiplegia, can he have aphasia? No, the lesion causing the left-sided hemiplegia is on the right side. Right is not the dominant hemisphere. Okay, so a left-sided hemiplegia patient, the lesion causing hemiplegia cannot cause aphasia. Remember that. But if still the patient is aphasic, it means he has another lesion on the left side, dominant hemisphere. That is why I told you at the beginning. See, the idea is to find out where is the lesion. Is it single, multiple, diffuse, or syndromal? Okay, hope you understand. So you have different types of aphasia. You have Broca's area. The Broca's area is affected. You will have motor aphasia. You have sensory aphasia, conduction aphasia, transcortical sensory, transcortical motor, and global aphasia. All these are different types of aphasia. So remember, if the patient is aphasic, your first inference means that the dominant hemisphere is involved. So these are all the symptoms of stroke. Okay. What what should you do when a patient comes with stroke? The first thing you do is stabilize the patient. Stabilize the patient hemodynamically. And as I told you, time is brain. So you'll have to find out, you'll have to do a CT to find out whether the patient is having an infarct or a hemorrhage. Remember, an early CT may not show the infarct because it might take about 12 to 24 hours for the infarct to appear on a CT. But the purpose of taking an early CT is to rule out hemorrhage and treat immediately. So if you ruled out hemorrhage, the first step is to do thrombolysis. If the patient has come to you within a time window of 4.5 hours, you can thrombolyze the patient with TPA. Thrombolytic agents, it's a clot buster. I told you, you will have an obstruction in the vessel. So the tissue plasminogen activator will activate the plasminogen and dissolve the clot. So re-establish circulation and the downstream brain will be reperfused. By doing that immediately, what happens is that the ischemic core will be lost anyway. This is the ischemic core. Surrounding tissue will be ischemic penumbra. Okay. By reperfusing early, the ischemic core will be gone, but the ischemic penumbra will mainly depend on the collaterals. Okay. The ischemic penumbra can be salvaged and the brain tissue can be salvaged. Okay. So that early treatment is important. So you'll have the patient comes to within a time window of 4.5 hours, take a CT, rule out hemorrhage and thrombolyze. That's the initial management. Okay. What other investigation will you do? And the first thing you do is stabilize and take a CT. You have to do a lot of other investigations regarding stroke. So complete blood count is important. Why is that important? Because polycythemia is a condition where it can cause excessive clotting, because of which you can have stroke. Similarly, CBC can reveal thrombocytopenia. Thrombocytopenia, a patient with thrombocytopenia is prone for bleeding, so if they can have an hemorrhagic stroke. So CBC is very, very important. Complete routine, blood routine you have to do. Blood glucose is important because there are certain conditions that can mimic a stroke. Hypoglycemia is one. Okay, the patient comes with hypoglycemia, they can mimic a stroke. All you have to do is do a CBG, document hypoglycemia, give dextrose, high dose, the patient will recover immediately. These are all conditions where you can treat and patient can recover immediately. Similarly, an RFT, renal function test, is important because again, electrolytes. Hyponatremia can cause altered sensorium, can even cause coma, and the patient is present like stroke. These conditions, if you correct hyponatremia, the patient will recover. Another important thing is hypokalemia, hyperkalemia. Hypokalemic periodic paralysis is another condition that can mimic stroke. All these investigations will tell you whether the patient is having a condition that mimics stroke. Okay? And LFT is important. A lipid profile you'll have to do because it's one of the risk factors. You'll have to do lipid profile. Syphilis serology is important. All these are important investigation, lab investigation for stroke. If you have a young stroke, if you have a patient who's young stroke, you'll have to do protein C, protein S, all these all prothrombotic states has to be ruled out. And also a cardiac cause of stroke has to be ruled out in a young stroke. Say for example, the patient having a rheumatic heart disease, you can have an embolic stroke. So all these are investigations. So you have to do an ECG, and if you suspect a cardiac cause, go on to do an echo, 2D echo. Okay. I told you CT brain initially to rule out hemorrhage, and once you settle the patient, you can do an MRI, MRV, etc. The carotid Doppler is important because you have to see whether the blood supply through the carotid is going. Like I told you, young stroke, you'll have to do coagulation profile, autoimmune panel like ANA, beta-2-glycoprotein, anti-cardiolipin, all this you have to do. Okay. So I told you initially you have to give a clot buster. Once you've done that, suppose if it's a hemorrhagic stroke, if it is a hemorrhagic stroke, you cannot give thrombolytic agent because it will worsen the condition. The patient will bleed further. So how does bleeding affect the patient? See, the brain is in a closed space. It's in the skull, okay? So once the patient bleeds, what happens is that, one, the downstream is not, brain tissue is not going to get blood supply because of the output. Two, because it's in a closed space, if you have excess bleed, you will have pressure effects. You will have pressure, it will compress on the brain tissue and cause pressure effects. Thirdly, what happens is that the blood will break down, the blood products will break down. What will do, it will irritate the other blood vessels. Supposing there's a bleed in the base of the brain, it will irritate the blood vessels, and blood vessels will cause vasoconstriction, and you'll have a secondary stroke. So these are all the effects of bleeding. Okay. So if you have a bleed, what do? You don't thrombolyze, but other measures like anti-edema with mannitol, furosemide, you may use steroids. Okay, all these measures have to be taken, and importantly, you will have to control the blood pressure, because blood pressure, if it remains to be above a certain level, the patient will continue to bleed. Okay, you've done in an embolic or ischemic stroke. After thrombolysis, what you have to do is you can add antiplatelets, statins, and treat the cause. But the mainstay in a patient with stroke is to give good supportive care. You support the patient. Mainly nursing care is very, very important. Okay, you'll have to support the patient. Take care of his hydration. Take care of his nutrition. Prevention of bed sores. Prevention of contractures. Prevention of infection. See, if the patient is unable to swallow, the patient is having nasal regurgitation, insert a Rayleigh tube for feeding. The patient is bedridden. The patient cannot get up and go to the toilet. Insert a catheter that will prevent bedwetting and bed sores. So basically, you'll have to support the patient. That's the mainstay in treating patient with the stroke. Finally, you'll have to do rehabilitation so that the patient will do some work and earn money for himself. Okay, this is the basic thing you would have to, how you manage a stroke. Now, what are all the complications of stroke? One, the patient is going to be depressed. Two, you can have contractures, bed sores, aspiration, infection, and long term you'll have venous clots going to the brain and causing secondary stroke or pulmonary embolism. So all these are complications of stroke. So remember, stroke can be ischemic or hemorrhagic. 75 to 80% is ischemic stroke. It can be thrombotic or embolic. Hemorrhagic are mostly because the risk factor is hypertension. It can be from an aneurysm or an AV malformation. Okay. I hope you understand this class. Thank you.